All right, welcome to the Duke Spine Institute live stream. We're getting a late start today because our first case we did in room 2, which doesn't stream, and that was a hardware removal on a patient who needed their screws and rods taken out. So this case, on the other hand, we are live streaming. This gentleman presents with a herniated disc at C4-C5, pushing on the spinal cord, causing damage to the spinal cord and the nerves coming off the spinal cord at C4-C5. We're going to go in endoscopically and remove the herniation. So bear with me. Our patient is intubated under general anesthesia, fully asleep, and this is the right side of the neck, which is the side we're going in on, mostly left arm symptoms. And let's get started. So first thing I'm going to do is displace the trachea and esophagus. Shot. We need to be over 4-5, 2, 3, 4, 5. Could be a little bit south of where we are. That looks good. Shot. All right, AP. I need to check my front back. This is a quick AP. Jordan, quick. Make sure I'm in the middle. Looks perfect. Back to a lateral view. So you want to be in the midline of the spine as you go in, which we are. Shot. All right, very good. And shot. Okay, AP, I think I'm off to the side. Quick. And shot. Gosh, that looks like, go give me a good AP. That looks like we're in the middle, right? Yeah. It went right through the front of the disc. Is that possible? Lateral. Luis? Looks centered, right? Yeah. Jeez. That went right through the front of the disc. All right, let's just get another AP. Coker. Make sure. 2, 3, 4, 5. That looks, oh man, this disc is very badly damaged. Interesting. All right, lateral. Well, he must have a good annular tear in the front because that thing went in pretty easily. All right, but it looks perfect on the AP and lateral for what we're trying to do. Shot. All right, we're going to do a discogram. Patient's asleep, so it's not really an evocative discogram. We call it a chromo discogram. Chromo shot. Chromo means color. Everyone agree we are at 4-5. 2, 3, 4, 5. Everyone agree? Yes, sir. All right, there's going to be a tear in the front of the disc. I'm sure of it. Shot. There it is. Look at that tear in the front and the back. Wow, he's got a tear in the front and back. Look at all the dye coming out in the front, behind the esophagus. Retropharyngeal. Fascinating. And then look at the tear in the back with a large herniation. Show us the herniation. Can you see that, Henry? That bulge back?
Yes, we can.
Okay, let's get an AP. Good job, everyone. Coker. Watch it. Got it? And shot. We're going to see the dye leaking out on both sides. Look at that. All right, there is perfect. Show us the dye leaking out through the tear on his left going around his nerve root. There it is. You guys see that little tear and the dye leaking out around the nerve? That's what we're after right there. Good job. Lateral. All right. Now he has a very thick neck. I call it a football neck. And it's not bad in any way. It's just makes my surgery a little more challenging. The hell was that?
Oh, that was a tower clamps. Tower clamp.
Okay, so looking good. I'm going to give a little num-num. A little numbing medicine under the skin. Feel free to ask questions during the surgery. Type it up into your dialogue box on our chat, and we'll answer. We are live streaming on YouTube, Facebook, Twitter, and LinkedIn. 4mm incision. The whole surgery will be done with a 4mm incision. That's tiny, folks. Okay? Normally, this surgery would require a big incision with metal plates if you did a fusion, or a metal disc if you did an artificial disc. Now I'm holding the guide wire in position. Shot. and I'm checking with my x-ray. I'm checking the levels one more time. 2, 3, 4, 5. We're all in agreement. Looks good. You guys see the guide wire there?
Yes, we do.
Jordan is highlighting it with the arrow. You can see I'm coming down through our incision shot. I want to watch my guide wire, make sure it doesn't move backwards into the spinal canal. Shot. So you want to bring the dilator down to the spine. I've done this surgery now 16 years. Shot. We've done over 1,600 laser surgeries, Duke laser disc repairs here at Duke Spine in 16 years. And in the neck, we've done over 600 cervical. Cervical is not as common as lumbar. Lumbar, lower back pain problems are far more common. But what I guesstimate is that the need for cervical is probably 3 to 1. So out of 4, every 4 patients, 3 of them are lumbar, and 1 of them is cervical. It's just lumbar problems are more common with the discs. All right, well, let's get an AP. So we're starting to go through the front of the disc with the dilator. You can see that. I just want to make sure we're still in good position. All right, so you can see the tip of the dilator is in the midline. Show us the midline there. You got some squiggly lines, which is the Raytec. Yeah, that's the midline. You can see the dilator is right in the middle. That's where we want to be. It's perfect position. The reason Raytecs have squiggly lines that you can see on x-ray is so surgeons don't leave them inside the patients accidentally. All right, shot. Obviously, it would be almost impossible for me to leave shot this Raytec inside the patient, right? Why is that? Well, look at the incision. It's 4 millimeters. How are you going to stuff that Raytec into an incision 4 millimeters? So it's another advantage of the Duke laser disc repair shot is that our surgery tube is not an open surgery. It's endoscopic, and you can't really leave a foreign body within the patient. Shot. I'm going to bring down the tube. I'm going to move that dilator further back in a moment, but not yet. All right. I'm bringing my tube down. You can see it on the lateral view. Show us the endotracheal tube on the lateral view. Yep. Show us the esophageal temperature probe on the lateral view. Very good. So we got 2 things in the esophagus and trachea. One is a temperature probe, and the other one is a endotracheal tube. Shot. So we're at the back of the disc, right where the herniation is. I can feel the annular tear. That's what we're going to go fix. Shot. Now while I advance, see that? The dilator came back already. Interesting. Must be pressure, a lot of pressure. Good news is we got a big tear anteriorly, so I'm advancing pretty easily without much manual traction. Shot. Any questions, Henry?
Yes, we have a question from Oz on YouTube.
Hello, Oz. Welcome. Shot.
They said, "Morning, Doc. Can you elaborate further on the difference between physiological changes versus structural changes in disc pathology and why MRIs cannot see the physiological changes?"
Yeah, great question. So for those of you, this is a very intuitive and insightful question. And it comes back to what I've been teaching you all, and Oz has been watching for a while, about what causes symptoms when you have a herniated disc. And we have been taught as doctors over the years what causes symptoms is pressure, compression. Therefore, we go out with the goal of doing a decompression to get the pressure off something. What we're getting the pressure off of is the nerves, called nerve roots, and the spinal cord in the neck. And it turns out that pressure-related symptoms are actually a minority, small number. In my opinion, less than 10% of people's symptoms that come from a herniated disc. So where does the 95% of the symptoms come from? It comes from inflammation. And inflammation is not a structural finding, it's a physiological finding, okay, mostly. Now, if you drill down to inflammation with a microscope, or if you use assays to look for chemicals related to inflammation, you'll find them. Inflammation is mediated by cells. It's mediated by chemicals called cytokines. And you don't see cells and you don't see cytokines on an MRI, okay? But you can start to see some of the structural manifestations of chronic inflammation on an MRI, such as scar tissue and what's known as the high intensity zone, or HIZ, which is basically inflammatory tissue, like granulation tissue, which I've been talking about. So MRIs can occasionally see evidence of inflammation at the back of a disc. However, most of the time, MRIs don't pick up on it, okay? Because MRIs are not sensitive enough to pick up on it. It's just the nature of MRIs. All right, we're working now down here at the back of this disc, and we are looking at the herniation, blue stuff, and the annular tear. And you can see a pretty big herniation here. I'm removing it. There's a big tear. All the blue shows herniation. The white is the torn annulus. There is a little bit of scar tissue, but for the most part, this is a fresh tear. This is not an old injury that I can tell. This looks to me like it's probably a few years old at most, and more recent than that even. Look at all this fresh herniation. This is all very recent, like within 6 months, a year. I can't give you an exact date that it happened, but I can tell you this is not an old injury. All right, let's show our audience a video on how does a herniated disc cause so much pain for a patient. It's inflammatory, physiologic, it's not compression, and let's show how that happens.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Got it. All right, I'll just talk to her in pre-op. All right, welcome back, and now you can see how does a herniated disc cause so much inflammation. I will tell you, not all herniated discs have that much inflammation. It's not all of them, just some of them. So why is it that some discs cause so much inflammation and pain and suffering for patients? Well, nobody really knows. I don't even know. It's a great question. I'm going to flip. I don't know. I think there's definitely a genetic component to inflammation, that some people are more prone to inflammation. Some people are more prone to chronic inflammation. I mean, clearly we know that's true from diseases like rheumatoid arthritis, right? So you know for a fact with rheumatoid arthritis it's genetic. There's a genetic predisposition, there's a genetic abnormality with protein that causes or precipitates or promotes inflammation, right, in the smaller joints. And so we know for sure that genes do play a role in certain types of arthritis. Well, why shouldn't they play a role in disc pain or disc arthritis? I think they do. I really think they do. I see people with large herniations that have no symptoms, and I see people with small herniations that have horrible symptoms. So getting back to what Oz said earlier, is that structure like mass is not the issue. It's not a problem of too much mass pinching nerves with herniated discs. It's a problem of too much inflammation causing pain and symptoms, irritating the coverings around the nerves called radiculitis, irritating the covering around the spinal cord, causing inflammation of the dura, which then causes headaches and neck pain, right? And of course, if the inflammation is severe enough, it can actually cause a spread to the spinal cord or nerve roots and cause myelitis or radiculopathy, which is a dysfunction of the nerves or inflammation of the spinal cord. And if you get myelitis, of course you can get myelopathy as a result, which is dysfunction of the spinal cord, like balance problems, coordination problems. We see it. As a matter of fact, I just treated a patient last week. He came from Seattle. He's a kid. He had a herniation. They blew it off. They said, oh, not a big deal. But in Seattle, but he came here and we fixed him. And he was having spinal cord dysfunction. He was severely spastic. He had urinary incontinence. He had gait abnormality. All of this was due to mostly inflammation from the back of the disc getting on the spinal cord at, T, what was it, 1011? T1011? Yeah. So he was, He did great. He was myelopathic. And he was myelopathic mostly from inflammation, some compression. But the doctors made the mistake over in Seattle of ignoring the inflammatory, there's a herniation, ignoring the inflammatory component of the disc herniation and only focusing on the structural compression and saying, oh, it's not that bad, sleep it off, basically. And of course, that didn't happen. He became progressively paralyzed. And by the time he got to me, he could barely walk. He needed a walker. So doctors are inappropriately ignoring the inflammatory value of a disc injury, which to me, after years of doing this, the inflammatory side of the disc problem is 95% of it. The compressive side is minimal. I mean, it's rarely you need to do surgery for compression. Mostly the symptoms are of pain, especially back pain, leg pain, sciatica. Those symptoms don't come from compression. They come from inflammation. And there's the downfall of our profession, is ignoring the obvious, right? You can take your finger and pinch somebody's spinal cord, they'll have no pain at all. They'll just go paralyzed. So they get weakness, numbness, and tingling. Paresthesia, we call it. Weakness, numbness, tingling, of course, spasticity, reflex changes. So they get these changes in their function of their muscles and reflexes and stuff, and skin, nerve function basically. They get these nerve dysfunction from compression. But pain comes from inflammation. And it's the inflammation related to the disc herniation that causes the pain. And we're ignoring that as a society, as a profession. We are ignoring people's pain. And now they're getting addicted to painkillers, taking, marijuana or narcotics chronically, because we as doctors have long ignored their pain. That is a bone spur. And it's right at the back of the disc. That's a calcified area of the ligament. And we just have to be super careful. It's not pushing on anything, so I don't want to get too crazy with it. It certainly won't cause inflammation. The inflammation's caused by the nucleus. All right. Henry, how are we doing over there?
We're doing good. We
Any
have another
question?
question. Yes, we do. The
Sure.
next one comes from Oz, once more on YouTube.
All right, Oz.
And they ask, is it possible to see an MRI with no bulges, but the patient has severe symptoms requiring surgery due to inflammation you cannot see?
So that's a great question. So is it possible that a patient has herniated disc causing severe inflammation and you can't really see on the MRI, but they're going to need surgery to fix it? Yes, we do it all the time. We see it all the time at Duke Spine. That's what I do with my MRI reviews. I figure out where people's pain's coming from, even though their MRI may not show the source. Okay, but it's always a small disc bulge or tear. Wow, look at that, man. This is a crazy case. Look at this. This is segmental OPLL starting to form at the back of the disc. I just blew away that bone spur. You guys see that? And the spinal cord is right in there. These are the last fibers of the posterior longitudinal ligament. You can see a little crack between the fibers, and there's a spinal cord down there, which we're going to stay away from. Okay? We have no interest in messing with the spinal cord. We want to decompress it. Like in this case, he has compression, but we don't want to get too close. So obviously we don't need to get too close because we're removing the herniation effectively without actually seeing the dura. Are we okay, guys? Is that irrigation? Are we good? All right, I'm fine. Look at the tear in the annulus right there. Pretty crazy, huh? All right. Now, here's another bone spur. You guys see it?
Yes, we do.
Right here. But this one is not causing much symptoms at all. Okay? So I'm going to not mess too much with it. Okay? Because I can only make this patient worse if I do something to harm him while trying to get rid of the bone spur. But you guys can see how the laser removes the bone spur. And look at the channels in the bone. See those holes right there? That's what we call diploic bone. Diploic. There's two types of bone. There's cortical and diploic. Bone spurs have a cortical bone, but they also have a diploic center. So I just zapped away that entire bone spur. Pretty cool, huh? People say, oh, the laser can't get rid of bone spurs. Of course it can. The only people that say the laser doesn't work well are people who don't use the laser because they don't know how to use the laser. They've never done it. That's like somebody saying cell phones are bad. I mean, yeah, cell phones can be bad, smartphones, right? With all the social media corruption. But the fact that you have a phone that you can walk around with and have access to, calling people and communicating effectively with people anywhere you are, that's not a bad thing. Okay, I'm not debating about other things like TikTok, Twitter, all that stuff. But what I am saying is that it's good to have a phone. For those people who maybe remember the old days, we used to have to, if we wanted to make a phone call, like if my dad, well, he was a doctor, when he got called by the hospital, he had a pager. This is before cell phones. And if he got a page while we were out to dinner or driving, first thing he had to do is find a cell phone, find a payphone, I mean. Okay? Payphone machine. And they were in every restaurant, at every gas station. They were on the corners of streets, etc. And that's how people communicated. It was payphones, right? Payphones were these big hunks of metal booth. You had to put quarters in there and make a phone call. And of course, a cell phone is a much better thing because now we can communicate better. So anybody that says cell phones are bad, they don't know what they're talking about, okay? Yeah, maybe smartphones are bad, but cell phones are not a bad thing. They're good. They allow doctors to talk to the hospital, okay? So they're good. All right, we are almost done. About 6 minutes left, 5 minutes left, I mean. I'm in the other foramen now, on the other side. All right, what other questions do we have?
This next question comes from Edwin on YouTube.
Yeah, hi Edwin, on YouTube, welcome.
They said, I have a question, Doc. After the disc fragments have been removed, what fills the space that's left? Also, what is the long-term effects of the laser procedure?
Oh, wonderful, great question. You guys see what he's talking about, right? That space down there? This space right here, from bone to bone, what's going to fill that is collagen. C-O-L-L-A-G-E-N. And guess what? What used to be there was the annulus fibrosus, which is made out of collagen. So it's actually going to heal with the same stuff that it's supposed to be. In other words, it's a natural repair. It's perfect. So we are going to let this area heal with collagen. All right, I don't see any more herniation, but I want to check that foramen. So the annulus is made out of collagen, and it's going to heal with collagen, if that makes sense. So that's what we hope for. That's the best you can do. By the way, if you hurt your liver is going to heal with collagen, okay? If you hurt your kidneys are going to heal with collagen. If you hurt your bone, it can actually heal with collagen. If things don't go well, we call it a callus. But what I'm getting at is everything in the body heals with collagen. It just turns out that the annulus is made from collagen. So, oh yeah, I just need another minute here. I'm just looking out the foramen. I don't really see anything out there, but I do want to go do another deep dive. Looking good. The nerve root is right there. This will be the left C5 nerve root, and I don't see any herniation anymore. Okay, looking good. Just get these last fragments out, and we're done. All right. So we're finished. Yeah, I'm going to irrigate them out. And I'm going to show everybody that's watching. If you look carefully here, Henry, can you see this?
Yes, we
You
can.
see all these little pieces here on the blue cloth? Those are all pieces of herniation that have floated out. So once I release them with the laser, they floated out. And they've come out of the body. So this treatment with the endoscope and the tube is wonderful because you can float out all the pieces of herniation. We're just doing a little irrigation, getting rid of the blood and the pieces of herniation. One more. All right, if you have questions, type them up. I'll answer them for you face to face. But this is a single level, one level. We're only doing one disc. That's all he needs. And it's unusual because a lot of times we're doing 2 or 3. But type your questions up for me, and I'll come answer them for you, okay? All right. And again, this is a 4mm incision. Take. We lost probably 2 cc's of blood the whole surgery, which is about 40 drops of blood. Mostly water and irrigation you're seeing, but 2 cc's. Now, if you had done this surgery open, like an ACDF or an artificial disc, you would lose at least 20 cc's to 200, you know, and some surgeons will lose more than 200. We lost 2. All right, there's no surgery in the world that loses as little blood as we do. This is a bloodless surgery, essentially, and it's a scar tissue-less surgery. By the way, our patients never have trouble swallowing or hoarseness that you see with ACDF. ACDF is anterior cervical discectomy infusion, ACDF. That's where they put a cage and a metal plate. It's what all these doctors are doing, all these spine surgeons doing ACDFs and artificial discs. With that surgery, the ACDF, you're going to have hoarseness, you're going to have trouble swallowing for months and months and months. Okay? Let's show how small the incision is. Henry, can you see this?
Yes, we can.
All right. We don't have wound healing problems. Yeah, we don't have infection. All right, here we go. You can see the incision is 4 millimeters. You guys see that?
Yes, we do.
Just under 5 millimeters. Nothing. And it's going to be a little piece of tape and we're done. All right, type your questions up for me and I'll answer them. Great job, everybody. Our next surgery we're going to do is going to be a lady who did have a fusion on her back, and now she has what's called adjacent segment disease. It's the dreaded adjacent segment disease. Don't get fusions and don't get laminectomies because laminectomies always lead to fusions, okay? Avoid microdiscectomy, laminectomy. As a matter of fact, honestly, avoid most of these other surgeons, period. Because they're going to do one surgery which will lead to a second, which will lead to a third and a fourth and a fifth and a sixth. This patient had a fusion at L4-5, L5-S1, and now she has adjacent segment disease where the discs above the fusion have worn down and the SI joint has worn down and caused pain. So we're going to do a SI joint rhizotomy, Duke plasma rhizotomy, to get rid of SI joint pain, and we're going to do the 2 discs above her fusion, L2, 3, 3, 4, because she's having pain above the fusion as well. So she's having pain above and below. All right, that'll be our next surgery, so hopefully you can join us. Type up your questions, and I'll come and answer them for you. All right? Thanks again, everyone.
It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long.
It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did a
he
lot
did
of
a
Googling.
lot of research, and we found Dr. Duke to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
Before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve. And we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Duke will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So, go for it.
I said that it was so important that I said I'd pay for it. You know, because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks. We'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. Good morning, I'm Dr. R. Duke Majan, CEO and founder of the Duke Spine Institute, here with one of my patients who traveled from Mississippi,
Yes, sir. Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Duke Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg. And went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Duke here.
And what do we do for you?
You guys did a C3, I think 3-4-4-5-5-6 at the Duke laser disc repair surgery.
And before surgery, you had neck pain
Correct.
for how long?
It's been ongoing probably for about 5 years.
And then pain going from your neck into your right shoulder down your right arm.
Correct, just getting progressively worse, and that's kind of what made me finally to say I got to definitely do something about it.
Here we are less than 24 hours after your surgery, the Duke laser disc repair. You can see the incision right here, it's 4 millimeters. And do you still have that neck pain and pain in your arm?
No, sir, zero pain.
Gone.
Gone, completely gone.
Cured.
In shock. Results better than I actually anticipated, which is a good thing, right? That's what I'm here for.
Well, I'm not shocked. It's what we expect to see typically, which is good. The procedure works, and that's why we do it. It works better than anything else. Were you offered any other treatments?
Yeah, they wanted me to go look at a, what do they call a spinal deformity doctor.
Uh-huh.
And they possibly looked at like doing rods and pins and,
Yep.
and all that kind of good, the fusion and everything. So it just kind of,
Why didn't you want to do the fusion option?
long time recovery time and just more of a difficult surgery.
Yeah.
Much more difficult surgery. And me working in a house, I still want to have good quality of life in the future.
Yeah. Well, fusions have complications, a lot of complications. Scar tissue, bleeding, and pain. Are you having any pain right now from the surgery?
No, not at all. Just a little stiffness when I turn left to right, but that's par for the course.
Yeah, the stiffness is going to take some time to work out.
Sure.
You've had bad arthritis in your neck. Your discs were degenerated. You had degenerative disc disease and herniations and bone spur at C4, C5, C5-6. We went in and fixed all three. You will need therapy to increase the range of motion. It'll take time and you'll get better. Are you happy with your decision to come to Duke Spine Institute?
Very happy. I flew all the way down here from Oxford.
Yeah, very good.
So absolutely made the long trip. I fly back Saturday, and I feel much better flying on the plane than I did earlier. Just thinking, you know, I'm not on any kind of pain medication, none of the muscle relaxant. There's zero pain, so I feel more comfortable hopping on that plane.
And we did it all through a 4mm incision. You could actually see the incision with the little tube going in to your discs. I moved the tube from one disc to the next, and we went back to the back of the disc where the tear was, and I cleaned the tears up with the laser. So that usually does the trick of getting rid of the neck pain when it comes from a herniated disc. And of course, we unpinched the nerve roots that were going down your arm, so that's why your arm is feeling better as well. I don't expect any of that to come back. You should be pain-free the rest of your life. Just don't re-injure the discs.
Absolutely. I'm definitely glad to get my quality of life back. That's the number one thing.
Anything you want to tell your audience?
Anybody that's dealing with the same issues I have, I definitely recommend to come to the Duke Institute of, you know, laser surgery. It's a wonderful thing.
All right. Well, congratulations.
Thank you
Safe
so much. I
travels
appreciate
to
it. Thank you
and
so
Dad.
much.
And
We
you-
will.
Yeah.
Well, my dad lives in Tampa, so my wife's up there in Oxford taking care of her stuff up there. So
Okay.
worked out good to have my dad here to pick me up and drop me off at the airport tomorrow.
All right. Sounds good. Well, safe travels for you then.
Thank you so much. I sure appreciate it.
My pleasure. All right. I hope you enjoyed hearing from one of our patients there that had the Duke laser disc repair done, and obviously did very well, which is most of our patients. Our average is around 95 to 98% elimination of the back pain and leg symptoms. That's doesn't mean that we still have patients who don't get elimination. We just have an average of 98 if you ask all comers. So what do we just do with this case? This patient was a cervical Duke laser disc repair. He basically had a blown disc between number 4 and number 5 bone called C4-C5 herniated disc. And what was interesting is that most of the time when I do these disc surgeries, I go through the disc from the front to the back. Okay? So I'm entering the disc through the front, and then I come to the back where the herniation is hitting the nerve, and I remove it through a tube and a laser and an endoscope. What was interesting is his annulus in the front was definitely compromised, meaning it was ripped open as well. So we don't fix anterior annuluses because, quite honestly, there's no need to. We could if we wanted to, however, they don't cause any pain, and they don't cause cord compression or nerve root compression. All the nerve root and cord compression happens in the back of the disc, right where we are operating today. And you could see when I was done that we had decompressed the spinal cord and the nerves in the foramen, particularly the left side. There was no more herniations left. So I was very pleased. It was a single level case. We don't get a lot of single levels. Most of them are 2 or 3 levels that need to be fixed. All right, we'll take our questions.
This first question, excuse me, comes from Thomas on YouTube. And they ask, if that bone spur continued to grow, wouldn't that eventually cause pain and symptoms?
Yes, great question. So, first of all, bone spurs never cause pain. It's important to understand that. You've got to understand, pain comes from one thing and one thing only. And this is universally true for your entire body. It comes from inflammation. Now, granted, sometimes there's trauma, like a broken bone or a fall where you feel a sudden pain. But the pain that comes shortly after, within a few hours, even a few minutes, is called inflammatory pain. And it comes from inflammation. It's basically your body's inflammatory system attacking an area of your body to get rid of whatever's there, foreign body, bacteria, splinter, in this case a herniation, and it's your body attacking, kind of like the Russians attacking Kyiv,
in Ukraine. And they just line their tanks up and they drop bombs from airplanes. They shoot mortars and other types of rockets, and they just destroy the entire city. All right? And that's what inflammation is. It's destructive. And then it's also clean up, right? So you have inflammation. The tail end of inflammation is clean up and rebuild. Okay? So when you have a herniated disc, your inflammatory system, your body's repair system, is stuck into the destructive phase of inflammation. Stuck. Destroy, and the reason it's stuck there is because in like Russia and Kiev and Ukraine destroying the city, somebody's always fighting back, right? So Russia or the army will continue to shoot, continue to fire weapons, continue to destroy the city as long as someone's firing back, as long as there's an enemy there, right? Once the enemy's gone, they stop the destruction and start the cleanup and then the rebuilding. So the problem is with the herniated disc is your body never will clear out the herniation causing the inflammation. That's what the Duke laser disc repair does. I figured this out 16 years ago, that the reason why we have so much pain is because your body is stuck in the inflammatory destructive phase of repairing a disc herniation. It never gets past it. And that's why people have years and years and years of pain and their discs degenerate because the destruction continues. It's like leveling a city, you level your disc. Again, I discovered that at Duke Spine Institute, and the problem is other doctors don't know it. The other doctors have no clue about this. They just never figured it out. And so they're in this belief that, oh, when you have a giant herniation crushing the nerve and spinal cord, that's when you do surgery. What I figured out is, yeah, you need to operate in that circumstance, of course, but you also need to go in and clean out the source of inflammation, because it's the inflammation that's causing all the back pain and leg pain or neck pain and arm pain. Anyway, I do have hair, as you can tell. So I don't know if I fully answered that question. I went off on a tangent, but if not, Henry will circle me back on the point.
Given that, I think that was pretty set straight on if it would cause pain symptoms. But for now, the next question comes from Edwin, once more on YouTube.
Hello, Edwin on YouTube. Thanks for writing in.
They asked, if the laser procedure is so good, why is it that no one I know where live do that? Not trying to be political.
Sure, Edwin, thanks. We get this question a lot. So if the laser surgery is so good, why is it that no one does it where I live? Well, first of all, they don't know about it. And second of all, if they do know about it, they are stuck in doing more expensive type of treatments that make more money for the surgeon. After all, who decides what surgery you have done? The surgeon, right? Should be the patient, but it's the surgeon. Well, you got to ask yourself, why would a surgeon recommend fusion with metal over something that doesn't involve metal or fusion if the other one is much better? The answer is they're going to recommend what makes them the most money, and what makes them the most money is the fusion surgeries and the artificial disc surgeries. Okay? Now, laminectomy they'll offer too, or foraminotomy. The reason they offer these treatments is because they know that you'll be back again in a year or two to have the fusion done. So they're going to get 2 surgeries out of you rather than 1. They're smart. They're investment. They're making an investment in you. So they take a little out today, tomorrow they take a little more, then a little more. Meanwhile, you've had 3, 4, 5 surgeries, you're still in pain, and then they bring you back and say, oh, we got to do a fusion now, and they do a fusion. And then you come back, you're still in more pain, and because they didn't do all the fusion they should have done, and then you come back, I still have pain. Oh, pain management with my good friend over here who's going to do shots for another 6 months to a year, take more money from you, steal more of your life, okay? And then that doctor's going to send you back to me so I can do another fusion. I'm telling you, I've seen it 1,000 times. All right, 100,000 times, not 1,000. It is what's happening around the world. So you guys, people, are getting screwed by the doctors who are in cahoots with the companies that make the screws and rods. Okay? And it's become so apparent to me because this laser surgery is so less invasive, and I've shown it to all the doctors at the meetings, and they continue to do fusions. They don't even try the laser. Why? Because they know it doesn't pay well. You as a surgeon will not make much money doing the laser surgery. You're going to be poor. You're going to make a lot less money. You make 10 times more money doing fusions and artificial discs than you do the laser surgery. 10 times. So of course they're going to want to do that. All right, my 17-year-old daughter in the middle of a live broadcast. Sorry. Anyway, that should answer your question. Number one, they don't know about it. Number two, they have no way of doing it because it costs a lot of money to buy the equipment. And number three, financially, they're not motivated to do the surgery because they get paid 10 times less. So there you have it.
Next question comes from Oz once more on YouTube, asking, Doctor, do you require epidural injections or facet injections before laser surgery?
Hey Oz, we at Duke Spine do not require epidural injections before surgery. We don't require therapy, epidural injections, facet injections. We don't. We have evolved to a point where we believe those treatments are superfluous and unnecessary. They're truly put in place to A, generate more money from the patients by doing extra procedures that don't work, and B, put in place by the insurance companies as obstacles or hoops you have to jump through in order to get surgery. We feel they're unnecessary and that they are dangerous and that they don't give any long-term benefits to patients, so we don't require them. 17-year-old daughters. No appreciation for real work. All right. Next question.
Yes, next question, last but not least, comes from Samir on YouTube. And they asked, hi doctor, my neck curvature got straightened. How do we fix it? Also, while doing the neck surgery for herniated disc, if we have bone spurs which are causing pain, is there an extra charge for that too?
Samir. I love it, Samir. Thank you for writing it. First of all, there's nothing wrong with your neck curvature. The only reason why it's straight is because you're sitting in an MRI scanner probably, or you have muscle spasms that are causing it to look straight. Your neck curvature would go back to normal once your discs are fixed with the laser surgery. Second of all, we do not charge extra for anybody to take bone spurs out. It's all part of one charge. We have one charge, one fee, and it covers everything. The facility, the nurses, the hospitalization, what we do here, it's really outpatient. And then the anesthesiologist, the surgeon, it's all included in one fee. And you know what that is before you even come here. We can tell you what it is. And if we see bone spurs that need to be removed, like we just saw in this case, we take them out. We don't believe in gouging people or tricking people. We're very honest and open and upfront with you. And we find that we don't need to lie to people or trick people. We do just fine by being honest.
And that is it.
Thank you, Henry. Henry's done a wonderful job. He's also treated my headache, which I had earlier from my daughter, keeping me up late last night with her friends over at the house. And the next surgery we're going to do is going to be a lower back. We're going to start with the sacroiliac joints. This patient has both sides, SI joints, horrible pain, and she has a fusion at L45, L5S1. So all that extra force has been rocking on her SI joints for years. Now she has sacroiliitis, and rather than fuse her SI joints, like a lot of doctors want to do now to make more money, we just go in there and do the Duke plasma rhizotomy. We burn the pain nerves to the joint. It's a permanent fix. It gets rid of the SI joint pain permanently. No need for fusions. So it's a lot safer for the patient. Instantaneous recovery, like literally an hour. You can be up going back to work and doing normal things. And it's safe. We don't have complications from it. So safe, immediate recovery, and it's durable. There's no need for fusion of your SI joints. That'll be the first thing we do, and we'll broadcast that. And then right after Dr. Patel finishes the bilateral SI joint rhizotomy, I'm going to pop in and do her 2 disc herniations above her fusion. She has a 4551 fusion. It's solid bone. Now she's worn out the 2 discs above. I'm going to go and do laser there. I did not do her fusion. Somebody else did. She's traveling from, oh Lord, maybe Iowa. We'll figure it out. Texas. Sorry. For the people in Iowa and Texas. She's traveling from Texas here to Duke Spine. So we'll see you soon. Thanks so much.